Okay, once again, good morning. For those of you just joining us, I'd like to welcome you to our webinar on E&M Advanced Primary Care Management. Again, my name is Leanne Foster, and I am a member of the Provider Outreach and Education team here at WPS. And again, I'd like to welcome everybody to our session today. I do have just a couple of housekeeping items that I do need to go through before we continue with today's event. First is going to be about the training materials for today's event. The presentation is available for you on our training center, and I have asked Ashley to put a link to that page into our chat for today. If you have that already, you're all set. If you don't have that presentation, it is not a requirement for attending today's session, but if you'd like that for reference, it is available to you there. And you'll just look for the title of today's event, and you will go ahead and select download materials, and it'll allow you to download the presentation for today. As I mentioned, we are recording this session, and it will be available on our website without needing to access our YouTube channel for 60 to 90 days. After that, it will be available on our YouTube channel for as long as the information is relevant and accurate. And as part of that, with the posting on our website, you will also have access to those training materials. Questions today, we are going to leverage chat for those questions today, and I do encourage you to ask questions. Today's session was created and adjusted based on pre-submitted questions that we received today. We got a lot of pre-submitted questions just about what advanced primary care management is. So that is going to be our focus today and how to build that. So if you have other questions, please throw those in the chat. Don't hesitate to throw those out. I will be checking in with Ashley at the end of today's session, and we'll answer as many of those as time allows. If for some reason we get more questions than time allows, don't worry, I have you covered. I will be putting together a follow-up document that will be sent to all participants today with all of the questions and answers that we were unable to get to today, so you will get that. Also, our ultimate goal is to provide you with the best possible experience. We want to know how we can best serve you, and that doesn't happen in a bubble. Your opinion is extremely important. If we're doing something well, we need to know that we need to continue that. If there's something we could improve upon, we need to know that we could improve upon it to give our education more value to you and help you navigate the Medicare program more easily. So you'll have a couple of different opportunities to provide us with your opinion and that feedback that we do value, and we do look at all of that and use that to evolve our program. So you will receive a link, and I'd like to thank you now for taking a few moments to provide us with that feedback. This is our disclaimer, just stating that the material presented today is accurate as of today. And if you've worked with Medicare for any period of time, you are aware that Medicare changes, and it changes often. So just be sure that you're continuing to monitor official CMS communications, which includes the CMS and the WPS website, to ensure that you're following all Medicare rules and regulations. Also, CMS does prohibit the recording, screenshotting, or photographing of this presentation for profit-making purposes. And as I stated moments ago, we are recording this, so you will have that recording available to you if you need to see that again, if you have questions on what you saw, or if this may be useful to someone and you'd like to share this recording with them. I will be going through some CPT codes today, and this is just a copyright notice from the American Medical Association, just indicating that these codes are the property of the American Medical Association and that neither CMS nor WPS controls those descriptions. And we will also be showing you some codes that could appear on a UB04 837I electronic transaction, and this is a similar copyright notice from the American Hospital Association regarding those codes. All right, so that brings us to beginning our presentation today. To start out, I will be using multiple acronyms today, and while I'm not going to be going through all of these, they are here, and I wanted you to be aware of that so that you have them should they be helpful for you today. Which brings me to our objectives and agenda for today. So during today's session, our objective is to provide you with a better understanding of what advanced primary care management services are and how to build those, including documentation requirements. So today we are, as I said, focusing on that advanced primary care management, and we are going to talk about an overview of these services because they do combine some already existing care management services. We'll also talk about the billing requirements and the documentation requirements. So I'm going to start with an overview of what APCM services are. So in the 2025 final rule, CMS finalized a proposal that established a set of coding and payment guidelines for advanced primary care management services. So advanced primary care management is a bundled payment model that combines services that are already that included in care management and technology-based services that you may already use. What this does is it bundles them into a monthly payment, meaning that billing for these services is monthly, and it is something that is billed once per patient per month, and it's for services that are provided by clinical staff under a physician's or a qualified professional's direction, and we are going to focus on the components of that today. So this is something new as of 2025, and it combines services, as I mentioned, of existing care management services. And the services that it bundles together are principal care management, transitional care management, or TCM, and chronic care management, or CCM. And as I said earlier, you may already be billing patients for CCM, PCM, and TCM, and you may be billing for those individually. You'll also know that they are time-based codes. Typically, and we'll give an overview of these, but typically you need to meet a time threshold before you're able to bill for those services. Now, APCM does not replace these management services. Instead, as I mentioned, what it does, it's an alternative payment model that is intended to support the goals of CCM and PCM and TCM. But again, it's not a direct replacement or alternative. What it does is it's allowing for a bundled payment for a set of services that are reflecting the essential elements of care delivery for the care management services that are included. It's intended not only to improve patient outcomes, but it's also meant to reduce the administrative burden for providers compared to current coding and billing for PCM, TCM, and CCM. So where PCM, TCM, and CCM have time thresholds, again, APCM does not, and it is focused on the complexity of the care. So typically what will happen is a provider would generally bill either the advanced primary care management or the individual care management code, such as CCM, PCM, or TCM, but you're not going to bill for both. It's going to be one or the other, and it's going to be up to your office to decide which billing method makes sense for you. And today, we're hoping to shed some light on how to identify that or help you identify that moving forward. So advanced primary care management does have its own set of codes. We will be going into these codes in more detail later on in the presentation, but here I have listed those out. So we're talking about G0556, G0557, and G0558. Again, not time-based. They are based on the levels, and G0556 is the lowest level of APCM, with G0558 being the highest. So we all know that strong primary care services are an extremely important tool in improving our patient outcomes and access to care while lowering mortality and reducing healthcare related costs. Let's prevent the problems before they happen. So while the APCM services are subject to patient deductible and coinsurance, there's still a cost involved. However, that is typically significantly less costly than if the patient were to have to make a trip to the emergency department or incur a hospital stay. So again, the goal is really to improve preventive care, that primary care services, so that we can prevent problems before they happen. So APCM has a lot to improve care coordination between the primary care providers, their specialists, and maybe any other healthcare professionals that may be involved in that patient's plan of care. So it is customizable, much like the other care plan management services that are bundled into it. That continues with this. Again, it's intended to help provide comprehensive care while avoiding unnecessary costs, and that includes duplication of services, because there is a care coordination that's ensuring that the patient isn't having services duplicated. That care can be more individualized and patient-centered based on their condition and their health status. So it's going to vary from patient to patient. And as I stated, and you'll hear me say a lot, it's going to help reduce the instances of ER visits and hospitalizations. Some of examples of that can include self-management support to help the patient manage their health better. So for instance, you may have a patient with diabetes, and in that instance, it could include education to the patient on lifestyle changes that could help them manage their blood sugar levels and A1C, or it could be education on how to take their medication appropriately to manage their condition. Again, it's also meant to reduce the gaps in their patient care. Sometimes you may have a patient who's seeing multiple providers and they don't necessarily need to. Or you could see a patient that is seeing multiple providers because their condition is so complex. It just ensures that everybody's on the same page on that patient's care plan. Again, that duplication of services. APCM is intended to be a proactive approach versus a reactive approach to that patient's care, because again, preventing serious health impacts before they occur is going to help reduce cost to the program, cost to the beneficiaries, but ultimately better patient outcomes, better health for that beneficiary. And it helps eliminate where we see there are gaps between the amount of time between visits for a patient with certain conditions. There's also a benefit to the provider community. It can streamline the billing for the provider community because, as I said, it bundles elements of multiple care management services into one service. So you're billing once a month for all of those elements, which we will talk about. It also provides clear reimbursements by using codes that are reflecting the complexity of the primary care services provided for an individual patient. They've adjusted that reimbursement model. And as I said before, and you'll hear me say this a lot, remember that PCM, TCM, and CCM all have time thresholds that must be met before they can be billed. And APCM does not have those time thresholds, because it is based on the comprehensive nature and complexity of the services that are provided. So as I stated, APCM is combining 3 different care models, and we're not going to go into detail on PCM, TCM, or CCM today. Those are training sessions in and of themselves, but I am going to go through some highlights so that you can recognize whether or not advanced primary care management might be something that makes sense for you. I have, however, asked Ashley to put links into our chat for YouTube videos that are regarding PCM, TCM, and CCM if you would like more information than we're going through today. So starting with principal care management. So principal care management is a service that is aimed at improving the quality of care for Medicare beneficiaries by focusing on a single high-risk condition, which is expected to last at least 3 months and is something that is serious enough that it requires ongoing care, and it poses a significant risk of hospitalization, exacerbation, or functional decline, or even death to the patient. It is not something that is solely based on diagnosis because it can be different based on the patient's health status and what's going on with that patient. And that is something that is going to be decided by the provider and is something that they are going to need to document. An example could be maybe the patient has severe rheumatoid arthritis. Again, that is just an example, and it could vary again, based on patient. So the providers are going to need to determine how serious that patient's condition is and if it's serious enough to warrant focused management by a single provider. When they're billing for PCM codes, they are using CPT codes 99424 through 99427, and I include those again to help you identify whether you're billing for services that maybe would fall under something that would be included in advanced primary care management. It is, the provider would need to spend at least 30 minutes on care coordination for PCM before they can actually bill. Again, this is that time threshold. And that care coordination is going to include things such as monthly clinical visits. It could be medical evaluations. It could include prescription refills, chart evaluations. It could also include just ongoing communication and care coordination between all of the providers that are relevant to that patient's care for, say, the example, the rheumatoid arthritis. Next, I want to highlight transitional care management. So transitional care management for Medicare is meant to focus on helping patients transition from an inpatient facility. So this can include a hospital, skilled nursing facility, perhaps a rehabilitation center. It's meant to help them transition from an inpatient facility back to their home or a community setting. And what its purpose is, it aims to prevent complications, reduce hospital readmissions because they're just being discharged. We want to keep them from having to go back to the hospital. And again, just ensuring that continuity of care, making sure that there is a smooth handoff between that inpatient facility and where they're returning, whether that's home or some other community setting. So TCM begins on the date of discharge and continues through the 30th day. That includes that date of discharge, and all requirements of TCM must be met within that 30-day period following discharge. And as I mentioned, we're not going to go into the requirements for TCM, and we've provided you with that YouTube video if you'd like to dig a little bit deeper into TCM. It's important to note, though, again, this is transitional care management and they're being discharged. So for that patient to be eligible for this type of service, they must be discharged from an inpatient facility. So this is one of the care management services that's part of advanced primary care management, but it doesn't necessarily have to include this. It's pieces of it. So another piece of that to qualify for TCM is that the patient's condition must require a moderate or high level of medical decision making. Also, if the provider's billing for TCM, it's being billed using 99495 and 99496. And as I stated before, we are including this so that you can recognize whether or not you're providing services that could be considered under advanced primary care management. And those codes are also, I just want to point out, TCM is also based on medical decision making. And the last element that I want to talk about before we get into billing requirements and then the specific types of services that are included in APCM is CCM, or chronic care management. So chronic care management is intended to help Medicare beneficiaries with chronic conditions, and it's intended to help them receive continuous coordinated care. And this can happen through regular check-ins, care coordination. It can be, again, patient education, and its goal, as with all of these, is to improve health outcomes, reduce those hospitalizations, and support those patients in managing their conditions more effectively. So, for example, a patient diagnosed with diabetes and hypertension, that's also one of the Requirements for CCM: the patient must have 2 or more chronic conditions, and chronic is defined as a condition that's expected to last at least 12 months or for the remainder of the patient's lifetime. I just want to point out there are some conditions, diabetes and hypertension, they're typically considered chronic, but it could be different based on the patient. So it's not based solely on the diagnosis, it's based on the documentation that this condition is going to be chronic for that patient. Doesn't necessarily have to include the word chronic, but it has to show that it's expected to last 12 months or has lasted the 12 months or for the remainder of the patient's lifetime. So back to my example of the patient that has both diabetes and hypertension, those are 2 chronic conditions based on the documentation in this hypothetical, and that they are expected to last beyond 12 months. So this patient also has had multiple hospitalizations for heart failure in the past year. So this is somebody that would qualify likely for chronic care management. Now, CCM also has a time threshold, as all of these do, except for the advanced primary care management. And in order to bill chronic care, the time threshold is at least 20 minutes of care coordination services per month in order to bill for CCM. And there are several sets of codes that are used, and they're based on these thresholds as well as who performed the services. So was it the physician or clinical staff that are eligible to bill for CCM? So 99490 and 99439 are codes that are used by clinical staff for non-complex CCM. 99491 and 99437 are for your physicians, your MDs and DOs, or other qualified health professionals that are going to be under CCM. Again, we gave you links to that YouTube video for more information on that, but that are eligible to bill. Complex CCM codes, we do get into 99487 and 99489 for clinical staff, and then there is a set of G codes for the MDs, DOs, and other qualified health professionals, which is typically going to be your clinical nurse midwives, your nurse specialists, your nurse practitioners, and your physician assistants when we're talking about other qualified health professionals. So next we'll get into billing requirements. Again, we were just talking about the elements of existing care management services that are part of advanced primary care management. And again, this is an alternative billing method. You will not bill for APCM and PCM, TCM and CCM. It's going to be a one or the other situation, and you will have to make the determination based on your practice, based on your patient, the patient's needs, their healthcare status, which care management method makes the most sense. So APCM is billed once a month, okay, and includes those elements we just discussed because, again, it is that bundled service, and it's intended to strengthen primary care as well as making billing simpler. So APCM is billed once per month. I do want to apologize. There is one extra bullet on your slide that should not be there that talks about APCM needing to meet time thresholds. That has been removed. That it does not need to meet time thresholds. It is based on patient care and how comprehensive and complex that patient care is. So again, it's billed once a month. The codes that are used to bill it are G556 through G558. And again, not time-based, based on complexity. And essentially, you can think of this as 5.7 is the lowest level of APCM, 5.7 is a mid-level, and 5.8 is the higher level of care. And we're going to talk about the specifics for each one of those here in a few minutes. This does, when you look at the codes that I just showed you for the elements that are part of APCM, this does simplify the coding. We're talking about 3 codes versus if you're billing for PCM, TCM, and CCM, there's kind of this laundry list of codes. Not a ton, but there's definitely more than 3. And that can simplify that billing. So let's talk about the services that are included in APCM. So the first and foremost is that the provider must get written or verbal consent from the patient to participate in APCM services. This is not unlike the elements that are included, particularly for chronic care management. So it does need to be documented in the patient's medical record. And I do want to call out that it only needs to be documented the one time. This is not something that needs to be received from the patient. That consent does not need to be received from the patient every single time they're seen as part of their APCM service. So it does also need to inform them that only one provider can furnish and will be paid for APCM services during a calendar month. So they aren't going to receive APCM services from every provider involved in their care. The idea is this is a focused advanced primary care management. So this is a focused coordination of their care. So whomever is that focal point, whomever has that longitudinal relationship to coordinate their care. The patient also needs to be informed that they have the right to stop APCM services at any time. Okay, they are not locked into any period of time. If they choose to cease receiving APCM services, that is their prerogative. It also needs to make them aware of that there is cost sharing. Now, cost sharing to the beneficiary, as I mentioned, is deductible and coinsurance. And while that is still a cost to the patient, this can reduce their trips to the emergency visit or emergency room, their trips to urgent care, hospitalizations. So in the long run, one visit to the emergency room, one hospitalization is going to surpass the cost of that deductible and coinsurance. Next piece is that the APCM services must be patient-centered. So as we talked about earlier, they are individualized. The services and the care plan is individualized based on that patient's health status and their condition and what do they need. And that can vary from patient to patient. There does need to be an initiating visit. That initiating visit is required for new patients and it is payable separately from an APCM because that's going to be essentially a new patient visit. You do not have to do the initiating visit if your provider, you as the provider or your provider or another provider in that same practice has seen the patient in the last 3 years. Okay, so it's required for those new patients. It's also not required if you've provided another one of the care management services in the past year. So that would include the PCM, the TCM, and the CCM. Essentially, there's already an initiating visit included in those, so you wouldn't have to do another initiating visit. You'd still have to get that consent as you go into the advanced primary care management services. Also, that initiating visit is not. Oh, sorry, I already said that. It's if you've already done those other care management services. My apologies on that. So the next thing is that ACPM must have a component in it that allows for 24/7 access and continuity of care. So the access and continuity of care, we'll start with the access. What that means is that they need 24/7 access to the provider or a member of their care team for that patient and their caregivers with any urgent needs. So maybe, it's after hours and maybe they have breathing problems and they're having an episode, or maybe they have hypertension and their blood pressure is spiking. They need to have access to contact the provider or member of that care team. Remember, the idea is to reduce the ER visits. So this helps facilitate that goal by them not automatically going to the ER when that happens. How you set that up is a business practice. So that is something that you would have to determine what that looks like. Is there a phone number that they can access? Is like maybe there's like an on-call type line. That's just an example. Again, that is something that you for your practice would have to set up. Now, the continuity of care is going to include things like real-time access to the patient's medical information. Maybe that is some type of portal with that information. It's going to allow for the ability for the patient to schedule successive, so multiple routine visits or appointments with a designated member of the care team. Maybe you're allowing them to schedule 6 months out. Maybe it's a year out. Maybe you want to see them every month. Depends on that care plan, but they need to be able to do that versus scheduling them one at a time. Again, we're trying to ensure that that gap between visits is less sporadic. Also, it needs to could include something like a care delivery alternative, an alternative to a traditional office visits. Maybe it is allowing for home visits, or maybe it's expanded hours. Again, that is something for your practice and your business. You'll have to determine how to set up, but those are just some examples. APCM also needs to include a comprehensive care plan for the patient. The care plan has to be available within and outside of the billing practice because, again, you're coordinating care. So other providers that are going to be involved in the patient's care need to have access. So you're just making it available as appropriate for those individuals that are involved in that patient's care, should they need access to that, should they need to see that. Again, so that everybody can be on the same page. Members of the care team, they need to be able to routinely access that. So whether that's through some type of an electronic system, however you want to do that, again, that is another thing that is up to your practice and your business. It's your business decision to decide that. And then you also need to give a copy of that care plan to the patient or the caregiver. It's allowing for transparency in what's happening with that patient's care. The next item that I want to talk about is care management. Now, this can include things like a systematic needs assessment. This can be medical needs. Can be psychosocial needs. It's just a systematic way of assessing it. It can be systematic approaches to ensure receipt of preventive services. Maybe it's reminders. Maybe it is a way of reaching out to them when it's time. Again, it's just an example. And then some way to reconcile their medication, manage their medication, but also some oversight of any self-management. So how is that being monitored? How is that being managed? Next, care coordination. I've talked about this a lot, but it includes coordinating things such as referrals to other providers. Again, we're talking about patients with likely more complex conditions, and so there are likely going to be multiple providers involved in their care. So you may need to refer them to other providers, other specialties. We'll also need to coordinate any follow-up care after an emergency department visit. Maybe they had to go to the emergency room. They're coming home. What kind of follow-up is happening? Same thing with hospitals, hospital stays, inpatient stays. So hospital, skilled nursing facility, or whatever other healthcare facility. Again, maybe a rehab center. What follow-up is happening after that? So that's kind of that transitional care management piece that's included in here. And this must include a timely exchange of electronic information with your other healthcare providers. So I mentioned the electronic health record. Maybe there's some type of a portal that you're leveraging. CMS does not lay out the requirements. They keep it pretty broad because, again, that's something that's got to be decided within your practice and within your business. Next, we're going to talk about enhanced communication opportunities. So you want to offer enhanced communication opportunities such as an asynchronous non-face-to-face consultation. So maybe that's happening through secure messaging. Maybe it's happening through email. Maybe there's a patient portal. Again, business decisions, but those are some examples. You also need to be able to conduct a remote evaluation of pre-recorded patient information. Maybe that's something that is a part of a remote monitoring system. Maybe it's something that's happening over the phone. Maybe it's happening through an electronic health record. Maybe it's referral services through that health record. But again, ways of incorporating technology into that patient's care. And then you also want to make sure that you're able to use patient-initiated digital communications that might require a clinical decision. So that could be a virtual check-in, that could be a some form of an online assessment and management of their care, of the services that we're receiving, or maybe there's some type of an online visit. The next two are going to get into the data piece a little bit. So the population level management, this means that you're analyzing patient population data to identify if there are any gaps in patient care. So we're again focusing on strengthening primary care here. So we need to look at, is what we're doing working? Is there a gap? Is there something we need to adjust to ensure that there aren't gaps in that care? And this could also include looking at the practice population. Perhaps you're looking at the population by diagnosis. Maybe you're looking at the types of claims that are being submitted, or maybe other data that you have available. That can vary depending on what data you have, what data you believe is valuable to look at. Again, to identify those gaps and ensuring that strong primary care. And then the last one is performance management. This is going to include an assessment of the quality of the primary care. It's going to include an assessment of the cost of the care, and then what meaningful use of a certified EHR technology is occurring. So we're looking at, again, that data to make some of those care decisions to ensure that we have a strong primary care model. So next I want to get into the codes that you will use to bill. Again, remember these are billed monthly and they do not have a time threshold. They're based on the complexity of care. And you're going to bill either of these, or if you're choosing to bill for the PCM, the TCM, and the CCM. You don't have to bill. It's not an absolute that you must bill APCM under certain conditions or PCM, TCM, and CCM. It is a decision that you will need to make based off of the patient's health status, the type of care, and the complexity and the comprehensive nature of that patient's care. I do want to remind you is you're not going to bill for APCM and those other care management services at the same time. So G0556 is going to be for a patient that has one chronic condition. Okay, and again, that chronic condition is not based on diagnosis. It's based on the definition of chronic, meaning that it has lasted or will last for 12 months or the remainder of the patient's life. So that is something that will need to be documented. And it isn't necessarily just the word chronic. It can be documented in a multitude of ways. But something that demonstrates that that condition is chronic. It is going to be provided by clinical staff, so that'll include the MDs, the DOs, physician assistant, and nurse specialists. The provider will need to be responsible for all primary care, and they are going to direct clinical staff in the care of that patient. And that provider is also going to need to be responsible for providing or coordinating all healthcare needs by that patient. So they have a longitudinal relationship and they are the continuing focal point of care. Now, I did see questions regarding G2211. That is not something that comes into advanced primary care management. That's a little bit different. We are talking about the services for advanced primary care management, but I didn't want to leave that question unaddressed or unanswered. So for that, I do want to point you to a webinar that we actually had yesterday. Ashley held a webinar on G2211, and there will be a recording of that if you were unable to attend on our Encore presentations page of our website and our YouTube channel. And that should be out shortly. It will likely be up next week. So that's something you want to keep an eye out for if you're looking for more information on that particular code. The next code is G0557, and this is going to include all of the requirements that we just discussed in G0556. As I mentioned, these are kind of different, these are varying levels, so this is a more complex level of care. So you have to meet the base, and then this is going to then be for a patient that has 2 or more chronic conditions. You'll use the G0556, and it has to meet, again, those specified conditions for chronic care, which we did mention and you do see here on your slide. So an example of this could be that you have a patient with diabetes and heart failure, or maybe you have somebody with asthma and chronic back pain. But again, they're going to have multiple chronic condition. It could also apply to patients that need care coordination for multiple conditions. So just looking at that patient's health status, what are their conditions, what are their needs, what is the level of care coordination, what's the complexity of their care plan. And then the third code that is used for advanced primary care management is G0558. G0558, again, includes everything that's part of G0556. It is going to be a patient that has 2 or more chronic conditions. So the big difference between G0557 and G0558 is that with 58, the patient is also a QMB, which means they're part of the QMB assistance program that is designed to help lower income Medicare beneficiaries pay for their Medicare costs. So that is the difference with this code, and that's going to be the only instance where you're utilizing this code. So I do want to talk about who can bill advanced primary care services. So APCM services can be billed by physicians, so both your MDs and your DOs, and they can be billed by non-physicians, but only certain ones. And the non-physicians that can bill this are going to be your physician assistants and your clinical nurse specialists. So keep that in mind. It is going to impact whether or not you can bill for these codes. And as I mentioned in the previous slides, the same requirements apply. They have to be responsible for all of their primary care. They have to have that longitudinal relationship, and that they are the focal point of healthcare. They're coordinating everything that's happening with that patient's care plan, whether that is, they may not be performing all of the services, but maybe they're coordinating maybe additional specialties. Maybe there's therapy or things of that nature. They're coordinating all of that. And they have to get that written patient consent. So APCM can be billed under Incident 2. They do need to meet the Incident 2 requirements. So this includes the licensure for the qualified healthcare practitioner that is providing the Incident 2 services, and the services that they're providing has to be within their scope of practice, along with meeting the general supervision requirements. Incident 2 is something that can be its own class altogether, so we're not going to dive into Incident 2. I just wanted to make you aware that it can be billed Incident 2. However, I have asked Ashley to throw a link in the chat to a recording for Incident 2. Also coming up in September, we are going to be offering a live event on Incident 2. So if that is something that you're interested in, I do encourage you to attend that. Before we check in for questions, I do want to go through documentation requirements. So we've talked about a lot of this already, but I wanted to have it kind of condensed in one spot for you. So first and foremost, we do have to have documentation of the patient's consent. It does need to be in the patient's medical record, and typically you're probably getting that as part of that initiating visit, unless that initiating visit isn't required because it's already occurred through another care management system, or you or another provider at your practice has already seen that patient. So this is going to be, again, those new patients. But we're going to need that patient consent regardless of whether or not there is it is a new patient or established patient. I kind of combined those first two bullets. My apologies for that. But you do need to document that, again, once, not every visit. That initiating visit, as I said, if it's not required, you do need to document why it's not required. So make sure that that is included in there. Otherwise, you do need to document that that initiating visit happened. You also need to document what their care plan looks like. What's that comprehensive care plan for that patient? So it should include what conditions are being treated, what is going to be monitored through the advanced primary care management model, and then we also need the assessment of those conditions so that we have kind of level set. We know where that condition is. We know what those conditions are. And then it also has to talk about what services are provided. What did you do in that visit? And each visit you'll need to be assessing the conditions. You'll need to provide those or provide information on the services that were provided. That's not typically different than what you do for any other service. So not wildly different. Also, that comprehensive care plan does need to include goals. So what are the goals for that patient? Do they need to get their A1C levels down? Do they need to get their blood sugar level down? Are we looking for their hypertension to be at a certain level? Are we managing their pain adequately? And are we getting that down to an acceptable level? And if those goals aren't met, what are the next steps? Certainly, a care plan is going to be adjusted if that patient's not at goal. And again, it's going to include those elements that we talked about a few slides back of all of the different elements. Now, I do want to point out with the elements, and I'm just going to go back to the elements, sorry. One moment, just want to have those up as a visual. Sorry, slide deck got stuck. Oh, and then it moved. My apologies. That's what I wanted. So these are the services that we're talking about in the documentation. You want to document this. Now, you might not have all of it in every visit, okay? So that's not necessarily a requirement. It does need to be a part of the services, but you want to document what you can of the elements. And again, we're not looking for a novel. We do want this to be streamlined and simple, but we need to be able to identify it as an advanced primary care management service. So before I check in with questions, I did just want to make you aware of some resources that I have provided for you. One of the items that you'll see is going to be a CMS page on advanced primary care management. And I'm just going to go out to that quickly. So on the CMS website, now you have a link that will take you directly out here, but I like to search. And there is a link that CMS has. They have a page dedicated to this. It does include links to the final rule, and it does actually include a link to the beneficiaries page that talks about APCM. So this is something that you can share with your beneficiaries, especially as you're going to get their consent. So that's something that's available to you. I've also included pages specific to chronic care management, transitional care management that are available so that you have those if you'd like to learn more about those. Again, you have those recording. And then I did include information on the QMB program to help you identify whether or not that beneficiary is in that program. And then also I do have a link here for that final rule, so you have that. So with that, we do have a couple of minutes. So I am going to check in to actually see if we have any questions in the chat.
Hi, Leanne. We did have a few questions come in. And the first one is, did I hear correctly a nurse practitioner can't bill for APCM? Leanne, are you still on mute?
I sure am. Sorry, y'all. I just had a tickle in my throat and I did not want you to have to hear that. So, question about, and what I'm doing is I'm also accessing that page again. It went away on me. There we go. So this page does talk about who can provide those. So I talked about MDs and DOs, physician assistants, and clinical nurse specialists. And CMS does call out that NPs can provide that service. I apologize. That is something that I omitted from my slide deck. I do apologize for that. So nurse practitioners can bill for advanced primary care management. Thank you very much for asking that question. My apologies.
All right. The next question is, are there frequency limitations? Does 30 days need to pass between billings?
Excellent question. So it is once per calendar month. It may not be a full 30 days, but it is per calendar month. So you wouldn't be able to bill twice, say in August, but you could bill in August and you could bill in September. So it's looking for that calendar month. Typically, what we see is that providers are billing towards the end of the month so that they can account for all of the services and have the complexity level to bill for those services. So typically that's what we see. It's not required, but it's typical.
And it looks like there was a follow-up to that question, which was, if so, how is February handled? They've experienced denials for frequency.
And for some services where it is laid out that it is 30 days, it's going to be the 30 days, so you'd be into March. But with APCM, it is per calendar month, so that won't be an issue.
And that was our last question.
All right, well, thank you all for those. If you think of any more, we will give you an option to submit those questions. So to wrap up, I do want to make you all aware of a customer service process change that is occurring on August 4th. So in order to serve you better on our call center lines, we are always looking for ways to improve efficiency and ensuring that we can help as many providers as possible while those hours are open. So what's changing is that as of August 1st, they are going to be allowing one MPI or PTAN combination per call. And that goes into effect on August 1st. And again, as I said, they're doing that for call efficiency. They want to decrease the wait times for you. Because that can be frustrating if you call in and you're having to wait for a call center rep. So again, just trying to help all of the providers that we can. This is also going to allow for quicker resolution of inquiries because we'll already be in the provider information that we need to answer the questions that are coming in on that call. So in a couple of minutes, you are going to receive a certificate an email thanking you for attending. And this is going to serve as your certificate. If you're attending for continuing education credits, you are going to have a couple of things here. You're going to see a link to the survey. Again, that feedback is important to us, but you're also going to see your certificate of achievement that includes the date and the contact hours for this. While this is not a CEU, it can be submitted to your accreditation or certification body for contact hours toward those CEUs. If you didn't get this, a couple things might have happened. This may have gotten caught in your junk or spam filters, so please check that. And then consider adding it comes from our webinar software, which is WebEx Messenger. Please consider adding that to your Safe Sender list. If you're not getting these on a consistent basis, that could be why. The other option is that you attended by phone, and I simply don't have a way to systematically confirm your attendance to send out this email. In either event, you are not out of luck. What you can do, and we will give you the email address in a minute, you can email our education mailbox and tell me you need the certificate and that you attended. Just also include the phone number from which you attended so that I can confirm your attendance and I'll get a certificate out to you. As I mentioned, you do have another opportunity for follow-up questions. I will be taking those for 7 days. So anything that's related to advanced primary care management, send that my way to our education mailbox. Include the subject line for today, which is E&M Advanced Primary Care Management. You can use the abbreviation. Also made it really simple for you. If you click on the link in the presentation and the training materials. That will pop up an email that already has that subject line in there for you. Let me know your question and I'll get you a response. That subject line is really what's letting those that monitor that mailbox know that, hey, let's get this to Leanne so that she can get you a response for that. If you have claims specific or it's about something not related to advanced primary care management, those do still need to go to customer service because they'll be able to look up those claims. As I've mentioned a couple of times, your input is super important to us. So I am begging just a little bit, but if you would take a few minutes to provide us with some of your feedback, that would be very much appreciated because that is what helps us improve our education. I want the good, the bad. I want to know what you found helpful, what we could have done better to support you. We use that again to either maintain programs that are working or to adjust programs that maybe could use a little bit of enhancement. So please take a few minutes to do that again. I do appreciate that. There's going to be a couple of ways that you can do that. You are going to see a link in the chat. Click on that, it'll take you right out there. Also, when you leave, you will get a redirect that looks like the bottom image on your slide. That is not spam, that is not malicious. It is just letting you know you're leaving our webinar software and going into CMS's Qualtrics survey software. And I just want to share some enhancements that come off of that feedback, directly off that feedback. We do hear you and we do implement things. One of the big things that we recently implemented were chapters in our YouTube videos. Previously, we'd record our 1 hour long sessions and you'd have to move between, basically slide the player so that you could see the pieces that you wanted. What we have done is we've added chapters to YouTube so they're jumps and that they're based on specific key points within the material, which will help you get to the information that you want. We do realize and we recognize that people use these for reference material and we want to make sure they're easy to use for you. The other thing that you may have noticed when you signed up for this session or signing up for future sessions, we have also added training indicators. We want to eliminate any disappointment for you when registering and attending a session if it's not quite what you thought it would be from the description. Maybe you're billing for using a 1500 or 837P and you really wanted to see information for billing through the UB04, the 837I. We're adding training indicators that let you know, and there are definitions for those, but that lets you know what the target audience is for this a little bit more quickly. So with that will end our session for today. On behalf of myself, Ashley, and everyone on the WPS Provider Outreach and Education team, I'd like to thank you for taking the time to attend today. We're all super busy. We all have a lot going on, and we realize that sometimes carving out an hour of your time can be a challenging day. So we look forward to seeing you on future events. We look forward to those survey comments, and please include topics that you'd like to see in the future. This is also your opportunity to communicate what topics you'd like to see in our future events. So again, please take some time to share those. So again, I want to thank everyone. Have a great day. You may now disconnect.